Well, thank you very much, and so glad so many people came out, and Dan organized such a terrific session with absolutely impeccable timing, I have to say, Dan. Now, I don't know what it means that the attorneys stood in front of you to speak, and the two doctors are sitting on our butts, but so be it. So, just by way of introduction, I agree with my colleagues that this is a terrifically successful week in America, and particularly for American healthcare. It seems to me there's no bigger black mark on American healthcare than the fact that we've had somewhere between 30 and 40 or 50 million Americans with very, very poor or no access. And so that is a problem that is at least substantially solved by passage of this act. But I would like to make a few specific comments getting more into the realm of delivery and the delivery system, and I'll pick up on some of the things that Andy said. So clearly, many more patients will have insurance. That is a good thing for the delivery system because the delivery system is trying to deliver care, and we can do a better job when there's at least a little bit of cash available to do it. In particular, this is particularly important for the so-called public hospitals, and in California, the 22 public hospitals take care of more than half of all uninsured people in California. So this is an extremely important legislation to help public hospitals go about their mission. But in addition to just having insurance, one of the other great benefits, I believe, is the fact that this probably increases the durability of insurance. In the delivery system, providing care to people that have unstable states of insurance is very, very challenging. And this is not just people in the Medicaid program and Medi-Cal program who are constantly going on and off the rolls based on very small changes in income or assets. But people change jobs. They change roles within companies. And the fact that their insurance goes from 0 to 100% frequently makes delivering continuous care very, very difficult. And the coverage expansion and the coverage provisions of the ACA seem to provide some stabilization there. Another potential effect on the delivery system is a possible, and I use the word guardedly, a possible reduction in the cost shift. Most of you know that, for the most part, and Andy alluded to this, that the payments that come to the delivery system from Medicaid programs in Medi-Cal in California are generally not sufficient to meet the costs of the care provided. And certainly for people who are uninsured, it's insufficient, which results in delivery systems needing to shift costs from paying patients to those who are not paying. This should improve that somewhat, although I would say this is one of the great unknowns about the future, depending on the proportion of patients that enter the exchanges, what the payment rates look like from plans to providers going forward, but it certainly seems like it's in the right direction. A major challenge, as alluded to by Andy, and I won't go further, is this notion of access. We clearly have an access. We actually, in many parts of the state, already have an access challenge for primary care and specialty care. Some of it is based on the fact that low payment in the Medi-Cal program, but a lot of it is just maldistribution of providers. We have a unique opportunity in California. California has among the most restrictive scopes of services for non-physicians, whether it be psychologists, nurse practitioners, nurses, medical assistants, technicians. In order to solve this problem, we need everybody in the boat. Everybody needs to be able to practice at the top of their expertise, and we currently in California are not allowing everybody to do that. So this is perhaps a charge to the state legislature and all of us who have influence on them to look to expand the scope of service where appropriate so that everybody can practice delivery of health care to the top of their abilities and their license. Okay, so it was already alluded to, the notion of coverage expansion was the bulk of this legislation. And in fact, it's fairly lacking in its ability to drive improvements in quality and reductions in variation in care. There are modest provisions in the legislation, but they're relatively weak compared to the coverage expansion provisions. They largely rely on existing functions within the federal government and state governments to improve quality. They're pay-for-performance systems that have modest amounts of dollars at risk, public reporting systems that, interestingly enough, are only looked at by healthcare delivery systems. The general public virtually never looks at or pays attention to public reporting systems on quality and outcomes, and targeted penalties for adverse events. Part of the reason it's difficult, I think, to legislate improvements in quality is that, in truth, it is not exactly known by the delivery system how to do it. How do we actually improve the health of an entire population or of a subset of a population? I'm very hopeful that between the Affordable Care Act and the provisions in the meaningful use legislation, that at some point in the relatively near future, we will know a lot more about the state of health of Americans or the state of health of San Franciscans in order to be able to both incentivize improvement and actually deliver a better quality product from the standpoint of healthcare. But that will be a subsequent step. That's not in the legislation now. It will undoubtedly require further legislative action and hopefully another 5 or 10 years for Andy in Washington to make this happen. And then finally, I wanted to say a word about cost. That the thing that is most lacking in the ACA is real drivers to reduce cost. There are a few. Hospitals will get paid less for Medicare patients, and disproportionate share funds, that is the sort of additional payment that goes to take care of the uninsured, will go away. So there will be that, but that's a very modest change and pales in comparison to what we really need to do in this country to reduce costs. Some of it has to do with efficiency, some of it has to do with not providing services that don't add value to patients and families, but a lot of it has to do with realignment of everybody's work. And there are essentially, the provisions in the ACA provide some funding for experiments via the Center for Medicare and Medicaid Innovation. And there will be experiments going on, but they're not real drivers. Fortunately, those drivers are already here. The drivers that need to reduce costs are right in our community today. They're employers and patients and labor unions telling us all that we are spending too much and we need to find a way to spend less. So what I think the next phase of legislation has to be some way of crafting guidance for the best ways to reduce costs and the safest ways to reduce costs, because if the marketplace alone will certainly force cost reductions. Some of it will be really good, and some of it may actually be potentially harmful. So what we need to do is have legislative guidance and protection so that cost reduction happens in the safest possible way. And lastly, education and research, two of our most important missions at UCSF. What effects there? Well, I certainly think in the realm of education, this notion of can we produce more providers of care, whether it's primary care providers, whether it's nurse practitioners, whether it's technicians, whether it's nurses, et cetera, I believe we will be asked to do that, to literally expand the number of workers in the healthcare system in some manner. But which workers and in what manner and how it's going to happen remains to be seen, because as Andy mentioned, this notion of maldistribution is a real problem. We keep producing healthcare providers who keep staying in San Francisco. That actually doesn't help most of California. And research, I think there is an important call for research, because none of us really know what the effects of these changes will mean for the health of populations, whether it's the entirety of the United States or small populations within communities. We don't really have the data systems and the collection mechanisms to understand how to rapidly assess the effect of these changes on the health of populations, but we need to develop them. And I think we at UCSF, as well as other academic institutions, have to take on that responsibility to be able to rapidly understand what has happened to this population in the last 6 months. Are they better or worse? So I think there's a lot to do. This is a great opportunity, but it's really only the beginning of what's likely to be a very long journey. So thank you very much, and we look forward to your questions.